thank you everybody. I'll be presenting lamellar hole associated epiretinal proliferation, LHEP in short. So it is basically defined on OCT as a thick homogeneous material of medium reflectivity on the premacular surface, the epiretinal surface, and more specifically at the margins of the lamellar defects. It is typically in continuation with the middle retinal layers. It conforms to the contour without exerting traction. So it's a form of degenerative ERM rather than a tractional ERM complex. And they are thought to originate from the proliferation of Muller cells, as according to many studies, onto the epiretinal surface. So laminar holes along with LHEP are more likely to have larger tissue defects and disruption of the ellipsoid zone and poorer mean visual acuity in as according to many journals, many literature search in the past decade. So I'll be presenting two cases, two interesting cases. One is this was a 65-year-old gentleman with the 20 by 80 vision in the right eye with a lamellar hole and lamellar hole associated epiretinal proliferation. As you can see, it's quite clear in this. There's a stark lamellar hole epiretinal proliferation on the nasal aspect, as well as slight LHEP component on the temporal aspect also, along with the ellipsoid zone disruption. So we operated the patient. The patient had a multifocal IOL in place. And I'm stressing the point here that we have to be prepared about the diagnosis, because these are not routine cases as opposed to the routine lamellar hole surgeries or macular hole surgeries. They take time, and the membrane is quite tenacious and it's very difficult to remove. You require a lot of patience. And if you know in your mind that what you're dealing with, the things can become very easy intraoperatively. So this was the PVD induction. The PVD was already there, and then we had the staining with the BBG dye. Now you can see the negative staining in the center and the blue staining around the periphery. And the stark point is the negative staining, as opposed to the ERM, is of a very limited area. It's generally at the edge of the lamellar defect. The second point is routinely, if you want to peel a ERM, you would go from the ILM area and just peel off the ERM along with it. But here the membrane is so thick and embedded into the retinal tissue that the ILM actually shears off at the edge of the ILM and the LHEP area. Now you can see with patients you can get a cleavage plane after trying and retrying, grasping and re-grasping gently. And the contour, the texture is very tenacious. It's glial tissue. It's yellowish in color, and it is very, very adherent to the edges of the hole. So you have to be careful. You might not remove it in one piece, and you might have to do a piecemeal removal of it, but you have to be very gentle while removing it, because it can avulse the hole, enlarge the hole. As you can see, the yellowish membrane is being removed over the lamellar hole in multiple attempts. And this of course is an edited video, but it takes a lot of time to identify the plane. Again, restaining you do, and you can find the remnant ILMs which have not been removed along with the LHEP, and then you peel it as much as you like and as much as you deem necessary as per your case. And this case was then done routinely as other hole surgeries were done, and we went under air and put in SF6 gas. And after 6 months, the patient had a very good foveal contour with some ellipsoid zone disruption still there, but the patient improved to 612 parts vision, best corrected. The case 2 is very interesting because this is a common scenario we face, and the patient presented with the bilateral full thickness macular hole. And as it was a busy OPD, the technician does all the OCT scans, and you just have a cursory look. The patient had both eye cataract also, and the right eye cataract was a little more dense than the left eye cataract, and the vision was finger counting 3 meters in the right eye. And I just saw the OCT on the screen, and it was a cube scan, a macular cube scan. And you can see on a gross look, both eye had a macular hole, and these holes with these elevated edges and the retinal edema generally do well, they close well. So I did not give it a second thought, and I was confident I would go in the OT and do a routine macular hole surgery and come back in maybe 30 minutes or 25 minutes. But here we miss the point, because such newer anomalies like LHEP are, more evident when you do a high definition scan. They can easily be missed on the cube scan, and then when you overlook such small things, they can, end up in big intraoperative surprises and frustration. So when I looked retrospectively in the left eye scan, because the right eye HD scan was not very clear, now you can see that there is a LHEP on the temporal border and a LHEP component on the nasal border of the macular, or the edge of the macular hole. So this was a case of full thickness macular hole with LHEP, and we went for a combined phaco-vitrectomy in these cases, in this case. But at this point, I was still, unaware of the etiology, and I was, assuming that it would be a routine macular hole case. So after inserting the IOL and securing all the ports, we went inside and, did a core vitrectomy, did PVD induction, in this case without staining with the tricod. You can see the V's ring coming off the disc. Now staining with the BBG. Again, as in the previous case, there is a central negative stain, similar to what we find in the ERM staining also, but it's more confined dot at the center, and you can see the sheen while I'm removing it at the posterior pole, the sheen of the LHEP, and it is unlike the ERM sheen, which is actually over the retina and has a definite cleavage plane. Here you do not find the cleavage plane because it is embedded into the retinal layers. Again, you try from the ILM surface, from the ILM stained area towards the center, but it shears off at the edge. So you have to, keep peeling on over the unstained area, over the negative stain, in the hope that with grasp and regrasp, you will finally get hold of an edge. And once you get that, then the things become easy, and you can remove the, the epiretinal tissue over the hole successfully. Like now, at the supranasal part, we found that nick and the cleavage plane, and now it becomes easy because once it is folded over itself, you can make out the contour, the texture, the yellowish hue of the glial tissue. Similarly, as in the previous case, you can see this yellowish membrane is stuck, it's very adherent to the edge of the hole, and this is where you have to take care. You have to be very gentle. Some people have advocated inverting the epiretinal tissue and the ILM inside the hole, but what I do is I just remove it gently, circumferentially over the hole, just taking care not to enlarge the hole, not to avulse the hole, or to create a iatrogenic hole. So as you can see, the whole complex, the whole glial tissue complex, the homogeneous complex is coming out of circumferentially around the hole. Of course, it does not come in one piece, and you have to grasp and re-grasp. And after that has been done, you restain it with BBG, and in this case, we were happy to find two beautiful leaflets of ILM still remaining, and we made full use of those leaflets, and we just inverted it over the hole, and that was sufficient to cover the hole. No stuffing done here, and we went under air and put in SF6 gas. So this was a case in which I was, I was expecting a routine surgery, but because I overlooked the OCT scan. So never do a macular cube scans in these cases of low resolution. They are fast scans, but they miss the finer points of the OCT, and it's very necessary to thoroughly pre-evaluate every macular hole case to find such phenomenon, which is not very rare. And these are the post-op pictures, 1 week post-op, and this is a 3-month post-op, and nice hole closure. So to summarize, LHEP progressively increases, as in literature, both over the nasal and the temporal edges, and the horizontal diameter increases with time, and the ellipsoid layer changes also appear with time. But the important point is preoperative detection is important for tackling intraoperative surprises, and these can be very frustrating while you're operating if you're not prepared for it. Thank you.
Thank you, Vishal, for wonderful videos of this entity LHEP. Any comments from any of the panelists?
Like I have a question to Vishal. Can it be a macular hole associated epiretinal proliferation in your case? Last case, You are showing.
Yeah,
that's
that
part
was a
one.
full thickness macular hole with the epiretinal proliferation. So LHAP is described with full thickness macular holes also now.
Yeah.
Initially, it was with laminar holes only, but now the recent literature says almost 10% are associated with full thickness macular holes also, and these are really tricky. Professor Hassan, you have a
Yes. We have seen it and labeled it as an ERM with macular hole.
yeah.
So, Vishal, why do you call it as lamellar hole associated with the?
Sir, because initially the nomenclature started with the lamellar hole. Now, actually, it is a epiretinal proliferation, but
Yes.
because initially full thickness macular holes were not reported to be associated with it, but now there are many reports of full thickness also being associated with the epiretinal proliferation.
So Vishal, can you stain this eyes initially after you peel off the PHF using Reti blue or Trypan blue?
Sir, they unlike the normal tractional ERMs, they stain very poorly with trypan blue also.
Okay. So you see, I have sometimes stained this, and still I agree that staining with even with higher concentration of Trypan blue, it does not take it. Just shows the picture of negative staining.
Yes, sir.
So anybody else?
Hassan, you wanted to make a comment?
Dr. Hossain? Sangeet, any comment?
So I think this. Can I have comment on?
Yes, Dr. Hassan.
As you said, it was first described for lamellar macular holes, and as you know, the lamellar holes are now classified into degenerative and tractional. And what you are describing is the degenerative type. There is no traction in the case, and usually it looks like the Englishman hat. But what I differ from what you are doing is that I do not remove the yellow tissue.
Okay.
Because it is a part of the retina. This is Muller cells. So what I am doing is that I peel it and then I put it again inside the hole.
Okay.
Because I don't like to remove parts of the retina of the retina. So I think there is no need to remove the yellow tissue. The yellow tissue is peeled and then it is put inside the hole. And in these eyes, usually I do a flap technique. So I put the yellow tissue inside the hole and then I cover it with the eye lamp flap. And sometimes the lamellar hole is so degenerated, as you said, and usually the visual results are much less than in the tractional type. So in this degenerative type, the visual results are poor
and the routine cases.
With the tractional type.
Agreed, sir.
Exactly.
One thing we can do is like we start the ILM peeling from the where the stain is there, and then you can come inside from like outside inside technique.
That's what I told you, sir. When actually it's so adherent, when you come to the unstained part, the ILM generally shears off. So it's unlike the tractional ERMs where it lifts the ERM also along with it. So it's not that, it's not the same actually.